Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Aebhric O'Kelly. This week, we are with Dr. Derrick Tin, who is a professor of critical care. He's the director of counterterrorism medicine at Harvard University and also a senior fellow in disaster medicine at Harvard. Derrick, welcome to the program.
Thanks for having me on your podcast, and really excited for this chat.
So tell us a bit about yourself and what's keeping you busy.
Yeah, so as you mentioned, my critical care background, a disaster medicine specialist, and that's sort of my academic side, which keeps me busy writing papers, the usual that academics do. And I'm also the global chief medical officer for two big multinationals, and that sort of keeps me pretty busy as well.
So you're deep diving into disaster medicine, and you've obviously have a huge connection around the world. But can you start from the very basics? What is disaster medicine, and what would a medic do to get involved in that?
Yeah, I think I get asked this often, right, when people hear about disaster medicine. Fundamentally, it's about being able to provide the best of care in the worst of times in a resource limited environment. That's what it is. It's sort of a cross between crisis management and public health. A lot of what we do, of course, there is the medical component, the clinical component that you have to understand, specific sort of clinical scenarios based on disasters. But a lot of it is also the soft skills that you need to learn. How do you sit at a high level leadership meeting and make people understand and prioritize why it's important to do certain things the medical way when a crisis hits. And I think that's a really sort of key component of a disaster medicine specialist. For people wanting to get involved, I often say, there are a number of pathways, depending on, not really actually so much depending on what you do, whether you're a paramedic, nurse, doctor. There's certainly a lot of courses around the world that will give you an introduction to it. And I think that's important because, and we teach this to our fellows every year at the BIDMC fellowship. If we teach them well, I always feel like if we teach a certain cohort well and they've never deployed in a disaster, they will quickly understand that, there are limitations, there are individual limitations, and it may not be suitable for you. I think we have a tendency to romanticize disaster medicine and the deployment. You're playing hero ball, but you don't really necessarily always hear about the downside of it. The trauma that you have to absorb, the subsequent PTSD that you could potentially develop, and often those are the people that don't necessarily have the same platform and voice. So I always try and give a very balanced view of what it is, and actually say, yes, you are doing good, but really, question yourself, is this appropriate for me? Am I really truly doing good on this deployment? What are the mission goals? What are your individual mission goals? So lots of important concepts to understand.
There seems to be a lot of crossover. You mentioned global health, and I'm sure even tropical diseases, that depending on where you go with disaster medicine, it sounds like a multidisciplinary practice.
Absolutely. And if you look at the history of it, certainly at the Disaster Medicine Fellowship at Harvard, we historically, it's always thought of, it's a branch of emergency medicine, or that's where sort of emergency physicians migrate to. And that sort of makes sense in many ways because, ED guys generally are adaptable. There's perhaps a resource constraint. You never know what's coming through the door, but you're sort of prepared for these crisis scenarios. But over the years, as we develop, we now have infectious diseases specialists that then subspecialize in disaster medicine. We have pediatricians, we have family doctors, we have military medicine guys, because there's a recognition that DM is very broad and it is actually really beyond emergency medicine. I view it as a standalone subspecialty that encompasses all of that. But there are different perspectives on that, and that's fine. But like any sort of budding, DM's only been around for 10, 15 years, so it's relatively new. It's only in the last couple of years that it's really gotten the sort of global attention. And like any budding subspecialties, there's always going to be this argument: oh, is it really a subspecialty as a standalone? Is it part of something bigger, or where does it quite fit in? But I think we are finding our feet, and there is increasing recognition that this should be a standalone subspecialty.
It sounds like there's a lot of pathways from different medical specialties that transitions into DM. How did this work for you? How did you get involved? How did you go from a specialist in critical care into a fellowship in DM?
Yeah, it's an interesting journey. I mean, and one that I reflect on frequently. Like many, I was just a emergency doctor for the first part of my career, and I even back then I had a very global footprint. Not many people know that I grew up in West Africa. I trained in London, worked in the US, did some time in Paris, in France. So even when in my emergency days, I was always keen to travel. And in the environment, I sort of understood and saw firsthand these sort of health discrepancies, the health inequalities that exist around the world. And I always knew that I would never thrive in a hospital environment. The four walls, being constrained in the four walls was just not for me. So I was always keen to explore, and luck would have it, I just got recruited one day on a mission, and deployed to the Indian Ocean, not really fully understanding the scope of what was about to happen. I just thought it was just a remote area hospital that we were sort of running, clinic. And on day 2, we had a boat sinking disaster, and I deployed out for my first deployment, 20 hours at sea, doing maritime rescues. And of course, that really set me on this path. For the next year after that's all I was doing. And, the amount of trauma I saw was just difficult to comprehend at times. But it really set me on path to really better understand this. And at the time, disaster medicine wasn't even really a thing for me. I've never heard of it. So we were running sort of field hospitals. We understood the basics of like triage and field hospitals, but there was no real template. It was just very organic. We were in a very resource limited area. And I kept doing that for a couple of years, and luck would have it, after that concluded, I got a scholarship to do a master's, and I chose it in the disaster world, so I completed that. And then, of course, shortly after that, landed at the DM fellowship in Boston at Harvard. And I think that marriage of operational experience and academia put me in this great position where I could understand both sides of the coin, and I can actually say, the academics, I understand where you're coming from, but operationally it's different. Practically it's different. And I can say that both ways. I was like, this is what we're doing practically, but where's the evidence behind it? Let's find it. So I think that puts me in a good position where I understand the spectrum of how medicine should operate as well. It should be evidence-based, but at the same time, not everything can be evidence-based, especially in the world of disasters.
It does make sense to have a transition from critical care into disaster. There's tons of critical care disaster medicine. You have tons of trauma, and I'm guessing there's a long, prolonged care. So you have PFC that's part of the catastrophe, and having your background in critical care medicine probably works really well for dealing with these prolonged casualties.
Yeah, I think it's worth remembering most hospital and something that still shocks me. I don't know whether that's an experience and that you share as well. You know, when I lecture in the hospitals and I speak to doctors that haven't really spent time outside of hospital walls, sometimes they haven't even seen an arterial tourniquet. Which is so bread and butter if you work in the pre-hospital world, and it's easy for us to forget that, especially if you come from a pre-hospital world, that actually a lot of a lot of clinicians have never stepped foot out of a hospital. So for them to suddenly go outside of their environment is very foreign. To do something that they're competent at doing in hospital, but to put them in an environment that's foreign makes that task very, very difficult. And we don't know how they're going to react. So yes, there is a lot of knowledge around it, especially in the last sort of decade or so. But until you step foot outside a hospital and do pre-hospital work in the field, in an austere environment, it's very hard to fully comprehend the scope of the task.
Is there overlap between disaster medicine and PFC, or do you include PFC in the disaster medicine courses?
I mean, I've certainly taught prolonged field care. I was in Zambia teaching that just before COVID, and to a bunch of park rangers who subsequently actually deployed into Cyclone Ida, which hit Mozambique a few months later. So it is something that's taught. We certainly try and incorporate elements of TECC as well. And prolonged field care, at the Harvard Fellowship, we run a pre-deployment course. It's usually 4 to 5 days long at the start of the year. And we get these guys out in the field to do and run scenarios like that. And once again, a lot of these guys have never been in the field. So it's a very foreign experience for them. The knowledge base is there, but as you and I know, when knowledge needs to also be able to be translated into actual doing.
It sounds like disaster medicine would be a profound shift for some of these, pediatricians or oncologists or radiographers. We all make fun of radiographers sitting in a dark room. So somebody wants to get into disaster medicine who's a medical professional. How do you train up these doctors, nurses, medics who want to practice DM?
Yeah, look, there's certainly a lot of avenues. I think I mentioned that earlier. There are now short courses, there are certificate courses, there are fellowships as well. They're still rare and hard to find, but they are, the ones that do exist are robust. So that's always, I think a fellowship is a very big commitment. So I always say, start with a certificate course and try and understand that. And if you feel that's something for you, you can join an NGO. There are lots of NGOs that do this sort of work and deploy with them and see if it's for you. And often people go on deployment, and I've certainly deployed, over the years with first timers. They go and they never come back because they're so traumatized by it. So, it's worth investigating at that level first. It's also worth saying I don't think every subspecialty, oncologist doing disaster medicine, I don't necessarily think that not that it doesn't bring value to the DM world, but are you really maximizing your core skill set and knowledge base in the DM world? I'm not sure, but I always feel that every medical professional should have some baseline understanding of what DM entails. It should be built into med school curriculums at that level. In fact, we not recently with Joshua Lane and American Medic published a paper surveying medical schools and the curriculum about this. So I think everyone needs to have a baseline knowledge and a certain cohort with specialties like critical care, pediatrics, family medicine, certainly the military aspect of as well. Infectious disease, as we know, with all the pandemic stuff that's been happening. These really bring a huge amount of value to the DM world as well.
So let's say you're king for a day, and what would be the perfect disaster medicine course that you would add into a medical school curriculum?
Oof. I think when I reflect back, right, like my first exposure to anything vaguely, not even, it wasn't even a disaster, it was an MCI event, was when I was probably about 7 years in as a doctor. So very late on. So, that not even med school, years as a practicing emergency doctor. So, it was very late on, and I never really had a chance to discover it and to understand it and to tailor my training towards something that potentially that's what I want to do. So, if I had the authority, I would certainly mandate that as part of the medical school curriculum, to have at least a unit talking about disaster medicine, and have a simulation, run scenarios, mass casualty scenarios. We do that at a hospital level, and some countries, some regions do it better than others. But as you know, it's one of those things. It's people feel like it's nice to have, but it takes a lot of resource and time to do, right? But I think at a med school level, we can start exposing students to this, then it really gets them thinking. I mean, these guys are our next generation, so we need to have them thinking early about, even if they don't end up doing it, but within whatever specialties, like how can I contribute to the DM world? Because the world is changing, as we know.
So at the moment, there are certificate disaster medicine courses. How long are they? Or let's say you could design the perfect course for a doc, medic, nurse who wants to get into this. What would that look like? How long would it be, and what would you have in it?
Yeah, well, I'm a bit biased because I teach on one at the University of Melbourne. Professor George Breitberg, who's a good mentor, colleague, and friend, runs that course, and there's a terror medicine unit as part of the DM certificate course. I think it's a really good course. It's very well structured. It can be done online as well, so it's very convenient for many across the world. And it goes through a lot of scenarios. We invite lots of guest speakers. I think it's I'm not sure the length of it. I think it's about 6 months long, but not like an onerous full time type course. So that's something definitely worth exploring. That's where I normally guide people towards if a certificate level course is what they're seeking. It is quite a big commitment, and there are certainly shorter, you know, online courses you can do as a sort of intro. But if you really want to dig deep, that's probably the first level. Of course, there's the European Masters of Disaster Medicine as well, run out of Italy. We have deep affiliations with them. I mean, the DM world is very small, as you know, so everyone sort of knows each other. And I was very honored to be invited one year to be there to really see how the campus block functions, and participate in their scenario sim that was done in conjunction with a number of agencies in that region. So that's a really really good course. It's very well developed. I would certainly advocate if you want to take it at the master's level, and then of course the fellowship level. I am hugely biased towards the one, the one I graduated from, and where I teach now. The Harvard BIDMC DM fellowship is the oldest in the world. I dare say it's probably the most established, with the best sort of content delivery network from the alums around the world.
So let's talk about the best of the best. So you teach on the Disaster Medicine Fellowship at Harvard. Everyone has heard of that little school in Boston called Harvard. Can anyone take that, or what is taught on there that isn't taught elsewhere, or why is that the best of the best?
Well, obviously there's an application process that opens a certain time of the year, and the candidates do get assessed. And there's a process that happens that's done by the faculty and the co-directors. So I can't tell you the numbers as to how hard it is to get in. I don't know the sort of application to acceptance ratio, but every year we'll probably get about a dozen or so. So it's still relatively small, but it's still one of the biggest ones in terms of annual intake. What differentiates us from everyone else? I don't know what everyone else does, so it's harder for me to sort of make that call. And I'm sure they do incredible work as well. I mean, for me, obviously, I am biased because you have the support there from an academic perspective. You have just so much resources. In my time in Boston, I could I remember in my downtime going to Harvard Law School, sitting in a lecture because I was an affiliate. I was always welcomed into the lectures, and it was a lecture by two professors of law that were involved in big disaster cases, legal cases stemming out of Haiti. They've been to Haiti themselves. So you find that there's a lot you can also contribute there, and there is just so much resource. I remember when Ukraine Russia broke out, going back to the law school and speaking to those professors and say, hey, there's something I don't really understand about, the Chemical Weapons Convention, or something that has a legal basis, or how does it work with International Criminal Court in terms of, if you break these conventions or the Geneva Convention, what happens? And they will sit you down and run you through it. To have that at your fingertips is incredible. And that's just one of many examples. I had the opportunity to spend 6 months doing a crisis leadership course there, and I'm now a global ambassador for that program, and meeting other healthcare professionals in sort of leadership positions. How did they deal with crises, and whether it's medical or not? The Boston Marathon, of course, comes to mind, and we had the chance to meet Deval Patrick, who was the mayor at the time, and he walked us through the process of, well, this is what I did, this is how I was thinking, these were the considerations. And this is so important for DM specialists to understand, because going back to what I was saying earlier, it's not just your clinical skills, it's all those soft skills, leadership qualities that you need to also understand to be an effective leader in the disaster world.
I can imagine having the resources there to just walk over to Harvard Law and talk to the best of the best about any of the legal issues. And you have Harvard Med there as well, so I'm sure there's crossover. But is it hands-on as well? Do you learn tourniquets? Do you learn pre-hospital trauma? Do you learn trop med, infectious disease? Is it hands-on?
Yeah, I mean, we do, as I said, we do a pre-deployment course. Initially, we teach the TCC as well. So we have days where we go away in the field. We spent some time with the Massachusetts Fire Department, looking at how they function in the field, how they set up decontamination units, looking through the tools they use for chemical detection in the field. And then if there's an opportunity, we'll deploy as a group as well. And we visit lots of different sort of centers, EOCs. So it's not just classroom based, not at all. I think we split the time being outdoors somewhere, and the classroom.
So tell us what. So you've obviously been to many disasters. What is the most difficult disaster or memorable disaster that you've responded to?
Oh, that is a tricky one. Look, they're all very different, and you sometimes it's when I look back, it's a bit blurry, and I don't know whether it's your subconscious making it blurry, so you don't recall all the events. It's certainly very traumatic. Some of them can be. So, and I think in my earlier days, when I had a much more, I wouldn't say necessarily a cowboy attitude, but I was younger. You come out of the emergency department, you feel like I can deal with this, and then once you're there, you realize, wow, this is completely different. Your mortality is suddenly being considered. And there are certainly moments I remember that I will just never forget. One of them was, on the maritime rescue, climbing up on the rope ladder to get up this ship, and I had my Thomas pack on. I was carrying an oxyviva in one hand, just climbing up, and I think it was like 4 in the morning. It was barely dawn, head torch on, and I just remember looking down and thinking, wow, I could just slip and I'll just drop into the ocean and that'll be the end of me. I had my safety vest on, but you just felt so small in this big world. And suddenly, at the time, I don't think I really thought much of it, but I still remember that moment just looking down and then moving on. But that moment stays with me even up to today. Of course, there are much darker moments that will stay with you. And seeing the deaths that happen, the trauma, or even in those that are alive, you just remember sometimes their faces, how they're in shock, in psychological shock, where they're just blankly staring. These moments stay with you. So I don't know that there's a particular disaster that was especially memorable, but there's certainly moments that will stay with you forever.
I can imagine the challenge of going to some of these and having physical and mental difficulties you got to face, and having that preparation is really important, and no one really thinks about the psychological stressors of the rest. There's probably courses out there, but yeah, the psychological stress of you being there, seeing all the death and destruction, and also having to face living in difficult environments. Um, from my experience in Haiti, I can imagine that, well, plus the risk of bodily harm in Haiti, that's always a challenge as well. Let
Mm-hmm.
alone you're going in to help people, and then if those people are then coming against you, it's adding more challenges. But yeah.
Absolutely.
So, Derrick, you're also writing the DM section of our new Field Guide edition. Tell us, what are you doing? What are your plans, and what are you adding to our field guide?
Yeah, I'm really excited. The second edition, as you know, didn't have a DM section, so I'm very honored to be asked to contribute. It's only 6 pages, and they're field guides, so it's very limited in words. I haven't quite decided how I'm going to frame, but it's going to be the core essentials. I think it's hard to condense an entire subspecialty into 6 pages, but hopefully I'll be able to get the core fundamentals, what's needed in the field. Some of it will be clinical, some of it won't. And some of the things you learn, children in disasters is a very good example, and something I learned to a fellowship. You think about, yes, okay, you deal with the medical side, but there's things like family reunification. A child's lost and they have no family. Like, what do you do with that? And these are things that clinicians don't necessarily think about too much. The needs of the children, the impact of it. And you touched on a bit earlier, the psychological element. It's something that I emphasize a lot in all my talks and lectures, just because I've got firsthand experience. of it myself. I've seen colleagues suffer from it. So it's something that I will always talk a lot about, and it's something that's important to talk about in the disaster setting that I still feel we don't do enough of. The psychological first aid, how do we support each other? What are the risk factors we need to be screening for? How do we mitigate some of these risks? There is a body of literature around this already, but it hasn't been very good at being translated into practice, even up to today. So
It sounds like the college needs to create a separate disaster medicine field guide.
Well, I mean, there is a Sphere guide. There are a number of guides around the world that sort of touches on these topics. Professor Ciotone's Disaster Medicine Handbook, of course. I mean, I call it handbook. It weighs about 15 kilos, I think. So not an easy one to carry. But that's really very comprehensive. I was also very lucky to contribute a couple of chapters in the last edition. But I constantly reference back to that, and we constantly update that because also it changes so much. I'm sure if you ask Professor Ciotone, when he launched the Disaster Medicine Fellowship, to today, the curriculum has vastly changed. I mean, the counterterrorism space, obviously, that's where I've developed a subspecialist interest in. The cyber side, the AI stuff, all touches all of this. And that's what makes it interesting, is it's constantly evolving in what you need to know and understand, because everything ultimately, going back to what is DM, it's about understanding how these events impact population health, right? So technological impact certainly contributes a lot.
So, what is the future of disaster medicine? Where would you like to see this go? What would you like to see changes within the disaster medicine specialty?
Yeah, I think we're already seeing the changes. Number one, we're seeing the fellowships crop up. The academic literature is now evolving. Certainly in the counterterrorism medicine space, the CTM space. When I started publishing, there weren't really many sort of authors in that realm. And whereas nowadays we're seeing all these publications prop up from not even affiliated institutes, just like other institutes. So there is that demand there because, as I said, the world is evolving. So where I want to see it, I definitely want it to see it as being recognized across the world as a standalone subspecialty with, robust curriculum. I think that's what everyone wants. And it's probably what it deserves. And then going back to what I was saying earlier is to really see this being introduced at grassroots level as a subspecialty that we expose medical and nursing and paramedic students to early on when they're training.
Have you thought about coming to SOMA and giving a talk on your experiences in disaster medicine?
Yes, I feel bad about Soma because I have been invited. I just never had the opportunity to go. So I definitely, this is what I'm truly passionate about, and I'm always happy to talk about it, to educate the world. I think there's still a gap in knowledge, and once again, I think I'm in a good position because I have both the operational and the academic experience. So I think, generally people tend to, I don't know whether you find this, right? Pure operators are very good at what they do, but they all often go, oh, what do the academics know? And the academics like, operators just doing, but, are they doing the right thing? Whereas there's now this cohort of people that sit in between. And I think we have a very powerful voice that we need to use to get buy-in on both sides for them to understand that we need to be in this together to develop this subspecialty.
It's difficult this year because Soma is on the same week as WADEM. Yeah.
Yeah.
So you'll be in Tokyo. So WADEM, the World Association for Disaster and Emergency Medicine. Tell us about WADEM. What is it, and why would we want to be involved with it?
Yeah, so we're hosting I obviously sit on the board of directors at WADEM, and we are having our conference in Tokyo in May this year, and then in Paris in 2 years' time. Really, it's it's a gathering of like-minded people to push the world of disaster medicine forward. That's essentially what it is. It's an academic and operational gathering. It's a home for all these people around the world that have an interest in this topic, that understand not just that they have an interest, that they have an understanding that there is a demand for this topic. I got approached by students from Nigeria, and they formed their own special interest group out of the medical students. So I was talking to them, and they some of the environments are resource constrained, so they really need to understand, and a lot of the lessons learned in the operational deployments, that how can they be applied in these sorts of environments. So yeah, if it's a not-for-profit organization. We have a large affiliated network. The board is very diverse. I think there's 12 of us on there, and everyone comes from a different region of the world, so everyone brings in this different experience. And our last conference in Killarney, I had such an amazing time just talking to people, seeing what they're doing in their world, and looking at all the publications that's been happening, and really understanding, okay, I think especially in Australia, you're quite siloed away from everything that's happening because we're so far away. We're a massive island, and no one really bothers us that much. So it's nice to go there and understand, actually, there are so many problems that around the globe that we can potentially help fix. So yeah, I encourage anyone who's interested in the field, even just you want to explore and do something different away from your normal emergency or critical care or whatever conference. I think you'll find someone who's like-minded, and yeah, I encourage you guys to attend.
Dr. Derrick Tin, my final question for you is this. What advice do you have for the new doc, the new nurse, the new paramedic who is just starting out in their career in austere medicine?
I think it really goes back to what I was saying. It's, there are so many avenues to explore this on a more superficial level. Do that first, but really take note of the mental health aspects of it. It's so under discussed. It's so poorly supported, and it goes back to what I was saying. We tend to romanticize the disaster world, these like deployments. You're going to play hero ball. The reality is often not like that. And my big word of caution is be very aware of your own limitations, of your own risk factors, and as tempting as it may be to go on a deployment, once in a lifetime deployment, just really think, how is this going to impact me? The one biggest advice I have, and I say this to the fellows as well, is have a good mentor. In fact, when I joined the DM fellowship, I said to Professor Seotone and Ms. Fuscanian, I said, I've got a fairly solid knowledge base already. I've got operational experience. I'm here to, of course, consolidate and learn, but what I'm really here to is to seek this mentorship, this support network, because I know from experience this is what's going to allow me to carry on doing the work that I do. Without that, you might just crash and burn very quickly. So let this be a word of warning, to always have that alarm bell at the back of your head when you consider these things. and reach out. And I always say this to people: I'm happy for you guys, anyone listening to this who is thinking about it, to reach out to me, and I'll paint a very sort of honest and true picture of what disaster deployments look like.
Thank you for that. That's really great to mention that the mentor, and you're stepping into the role of being available for anyone to contact you with questions.
Yeah, I mean, I think it's in our nature, right? In the emergency services, everyone from paramedics, ED nurses, it's in our nature to teach and to want to empower the next sort of generation replacing us to do better, right? We don't want our lived experience to die with us. We want to be able to impart that knowledge. And I still deploy, of course, but much more scaled down now. I've got a young daughter, so my risk appetite has certainly changed. But there's so much I learned that I wish at that time I had someone that could guide me through a lot of the stuff I had to go through. I mean, I did have that, so I'm very grateful. But nowadays, there's so much more knowledge around these topics and deployments, especially around the mental health side. So yeah, always happy to chat and support.
That's fantastic, and it was great to meet you in Sundsvall, the Tactical Trauma Conference, and seeing you pop up all over the world, and what you're doing, and the torch you're carrying in disaster medicine is making a difference. Thank you.
No, I really appreciate it. Once again, I love this topic. I'm really passionate about it. At the end of the day, it is about providing the best we can in the worst of times, right? And that's always my guiding star whenever I think about it. This is why we all do this. So thank you too for providing me this platform, and thank you too for all the work that you do, of course.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.